Good morning. Today we welcome Dr. Marcela Smid from the University of Utah Health. She is at UNMC today to talk about her wonderful work in pregnancy and postpartum and substance use issues. Welcome, Dr. Smid.
Thank you so much for having me.
First off, just kind of tell us what you got interested in this topic.
It's a little bit of a circuitous route. I was recruited to the University of Utah actually to do pregnancy after bariatric surgery research. And when in my fellowship, which was at UNC Chapel Hill, we were all required to get a buprenorphine waiver, which is thankfully not a thing anymore. We can talk about that a little bit later. So when I got to Utah, I was the only faculty member in the entire department that was able to prescribe buprenorphine, which is one of the medications for opioid use disorder. So all of a sudden, my clinic became the clinic, and I was in Europe, at my brother's wedding in Rome, and I was getting these panicked phone calls from our admin staff saying like, oh, she needs another prescription for one of my patients. And I came back and I met with our division director and was like, I will do this, but I cannot do this alone. And that's really where it started. And we just started developing our clinic called the SUPeRAD clinic. And we have a really big team that has grown over the past 5 years that started with my PA, Jasmine Charles, and I.
Wonderful. One of the things that I noticed right away in your presentation was that you said infants can't be born addicted to something. And I remembered all those videos I saw as a kid where a baby was born. It's like, this baby's already addicted to crack and stuff like that. But you say that is absolutely not true, correct?
So it's not you are correct. That is not true. And so one of the things out of my, talks I really stress is it's really important for us to understand what is and is not an addiction and how pregnant people and how their children are affected. So you can be born with physical exposure, so exposure to substances which may cause physical withdrawal symptoms. And that is what we should call them, right? So there are physical withdrawal symptoms that may need to be treated with medicines, and there are other interventions now that are non-pharmacological depending on the substance, but they can't be addicted because an addiction really is it's a chronic brain condition where the pathways in the brains have changed and there's compulsive use that causes distress and harm. And an infant cannot do that, right? An infant can show you that they are having signs of distress in terms of physical withdrawal symptoms, but they haven't had those brain changes. That does not occur with an infant. So it's really important to use the correct terminology. And so when you see those things on like Dateline, right? It's very stigmatizing to the and a lot of those, while they're trying to draw attention, I think do more harm than good because they don't contextualize what is happening. And sometimes physical withdrawal symptoms happen, for example, in about 50% of moms that are taking a medication for opioid use disorder like methadone or buprenorphine. Those kiddos may have some withdrawal symptoms. It's very similar to a mom who has diabetes and is taking insulin. So those kiddos can have low blood sugar, and we treat those symptoms. So it's an expected reaction of the medication. And by really sensationalizing and saying, this kid is addicted to whatever, heroin, crack, whatever, meth, whatever the substance is, it takes the attention away from what is a chronic medical condition that has treatments, and some of those treatments may have expected symptoms in kiddos that are treatable. And when we deconstruct that, it becomes a lot less scary for people who are going through that, and a lot less stigmatizing.
Cool. You had mentioned how substance use varies so much between men and women. Yeah. And how does that factor among pregnant women who are trying to attempt abstinence during pregnancy?
So I like to say I picked the best time to be an addiction medicine specialist because pregnant women, so women and men have some biological differences and some societal differences that probably play into addiction. There's a lot of attention to sex and gender, understanding the sex and gender differences with addiction. So one of the things that we know is that women compared to men go through a process called telescoping, which happens in all substances where they go from first use to a use disorder much more quickly than men. And nobody truly understands why that happens. There's some hypotheses. One of them is that there can be some of the hormones, so estrogen and progesterone can really affect those things. And there have been animal studies and studies in humans that really suggest that there are depending on menstrual cycle or even in pregnancy, that when you have a different hormonal balance, it's easier to abstain from substances. So likely progesterone, which is the hormone that we see, progestation, right? Progesterone in pregnancy helps to prevent from having cravings. And so 80% of women will stop using substances completely in pregnancy, whether that's tobacco or alcohol or heroin or meth, whatever it is, they will usually stop completely on their own. And the folks that continue to use most likely have the most severe substance use disorders because they don't want to be using. All pregnant people know that this is not ideal for them or for their baby, and they don't want to use. It's compulsive use. And so that's one of the biggest things that I try to drive home is that substance use in a person who doesn't have a substance use disorder is a choice. Substance use in a person who does have a substance use disorder is a symptom of the condition.
Now, this has been a problem that's gone on for generations,
Right.
But in the last 15 years with the opioid epidemic, how has everything changed?
So we see more death, right? So opioids, because they stop, if you take too many, you stop breathing, right? And you die. We're really seeing overdose deaths being a huge, just everywhere. And meth, I know meth is emerging, it's a co-occurring epidemic, and we're seeing fentanyl. And a lot now we're seeing the emergence of fentanyl, and fentanyl we're really seeing it in heroin, and we're seeing it in methamphetamines, and that is driving some of this overdose epidemic. And we're absolutely seeing it in pregnant people and postpartum people especially, because 80% of folks who are pregnant will stop using. But the flip side is also true, that once they're postpartum, many people who have been abstinent in pregnancy will have a return to use in that postpartum period. And it's actually one of the most dangerous times because you've decreased your tolerance. And so when you are exposed again, you may have those symptoms like respiratory depression where you stop breathing and you die. So you're much more likely to overdose in that postpartum period, specifically because people have tried to stop using or decrease the amount of use in pregnancy.
Now, what kind of treatment options are available for pregnant women during pregnancy and then in that kind of critical time after pregnancy?
So it depends really on the community that they're in. And it depends on the substance use disorder. So for example, for opioid use disorder, the best treatment is medication. That's really the first line treatment. That's the life-saving treatment. So that's methadone, buprenorphine, which is also Suboxone or Subutex, and naltrexone. There's not a ton of research in pregnancy, so some of those are evidence-based, and some of those are evidence-informed approaches. So I use those terms because we often are extrapolating from studies in other populations because it's so hard to do pregnancy-related research. But the research that we do have available is that all of those appear to be safe, and that it is safer than not being on medication for opioid use disorder because the risk of return to use is so high, particularly in that postpartum period.
Now, one thing I'm curious about with the opioid epidemic especially is that you hear a lot of politicians, a lot of people talking about how we got to get rid of it, how it's important. Do you feel like it's maybe easier to get funding to do research because of it?
Absolutely. So yes, I jumped on the addiction research train right at the right time because there really is, and to the credit, I think, of politicians and policymakers, there's been a lot of money that's been put towards research. So there's my clinic, we have 3 randomized control trials that we're doing right now. One of the things that I would say is that we do have to remember that this is the opioid epidemic is an epidemic that affects primarily white individuals, and that you had mentioned crack and cocaine, and that was a drug epidemic that affected primarily non-white individuals, and that same response was not there when we had the crack epidemic that was happening in the 90s, and it was really approached as a criminal issue, and we have to criminalize folks and we have to save the babies from their parents, as opposed to now we're really approaching it more as a medical problem, and there's much more research going into it, which benefits everybody, but we have to really acknowledge that not all communities were approached in the same way, and that's still true today.
Are there new treatments out there that have come up in the last 4 or 5 years that you feel like are effective and need to kind of grow?
For pregnant people or just people in general?
Say addictions in general, yeah.
So we've seen a lot more research in extended release preparation. So for example, SUPeRAD is the brand name of an extended release injection. There's another injection that's going to likely be called Brixadi that is an extended release. And that one we're actually doing, there is a randomized controlled trial right now in pregnant people that we are a site for that's randomizing between extended release buprenorphine, which is a shot, versus sublingual. And I think those really, for pregnant people and for non-pregnant people, those extended release really, I think, work a lot better. They just do. And you're not having to remember to take something every single day, and you can live your life and not focus on taking your medication and feeling bad, right? And so I think one of the things I emphasize is often with a person who's really in the depths of their addiction, the use is not about feeling good, and that's why that getting high is, it's not about feeling good. Usually it's just about not feeling bad. And I think when we have that perspective and understand why somebody has such compulsive use, we can have more empathy for that.
One last question for you, kind of going back to pregnancies. Obviously when a woman's pregnant and then right after they're pregnant or continuing on, very busy time, very stressful time, a lot of stuff going on. How hard is it for them to go seek treatment during, let's just say during the pregnancy, then the first year after, with everything kind of changing in her life?
So that's a great question. So I would say, based on the best research that we have right now, right? So, and anecdotally, I think it is extremely hard to do yet another thing when you have a small human. I have an almost 2-year-old, and they are very demanding on your time, and they don't really care what you are doing. They really want you to take care of them. And so I think it's super important for pregnant people and then postpartum people to have a team that's already in place, because trying to scramble and doing it postpartum, and especially, so in our clinic, we keep the moms for a year, because it doesn't, so even though that sort of traditional, we're an OB clinic, but traditional 6 to 8 weeks postpartum, I mean, people haven't even slept at that point, and asking them to transition to a different provider, bring their newborn, have between pediatric visits, lots of stuff going on during that time, asking them to transition to another provider who may or may not know them. And then they have to disclose all of their history. It's a really hard time to do that. So keeping moms kind of in the most stable place is usually the best approach.
Very wonderful. All right, well, thank you, Dr. Smid, for coming to Omaha and speaking with us today, and safe trip back.
Thank you.